Good morning, everyone. Valerie Shores is the seminar coordinator who will introduce our speaker and collect the questions you submit for her to ask after his presentation. Valerie?
Ian Shapiro is Sterling Professor of Political Science at Yale University. He has written widely and influentially on democracy, justice, and the methods of social inquiry. A native of South Africa, he received his JD from the Yale Law School and his PhD from the Yale Political Science Department, where he taught since 1984 and served as chair from 1999 to 2004. His most recent books are Politics Against Domination, Responsible Parties Saving Democracy from Itself with Francis Rosenbluth, and The Wolf at the Door, The Menace of Economic Insecurity and How to Fight It with Michael Gratz. His current research concerns the relations between democracy and the distribution of income and wealth. He is leading the seminar on politics and public policy in the United States, and his talk today is titled, "Why Does the United States Lack Universal Health Insurance and What Can Be Done About It?" Ian?
Thank you, Valerie. Can people hear me okay? Yeah, yes. Okay. I'm going to share some slides, so let me just get them up. Okay, so I'm going to, in these depressing times, and we've had a couple of depressing seminars in the last 2 days because of the topics we've dealt with, I'm going to give a talk today that I think ends on a somewhat hopeful note. So stay tuned. I want to start answering my question by just taking a little step back and thinking about the Affordable Care Act that was passed a decade ago now by the Obama administration, and it's what was achieved and what wasn't achieved. And then we'll go back and look at the history of health insurance in the US, the structural changes that are affecting the possibilities, and bring it up to the current crisis. So it is an important thing to say that for all of its limitations, and they are many, the Obamacare, or the so-called Affordable Care Act, was a remarkable achievement. In as much as all the way back to the Truman administration, we have had at least 5 attempts to enact universal health insurance that have failed. So Obama succeeded at something that nobody else in American history has actually succeeded at, namely passing comprehensive health insurance that, while not achieving universal care, massively expanded it. The one exception to this is in 1965 with the creation of Medicare and Medicaid, about which I'll have something to say shortly. But other than 1965, Obamacare is the only significant federal expansion in US healthcare. So the US system is unusual. After all, every advanced democracy has universal health insurance. Some of them are multi-party systems like we have in Europe, but we have in the UK a 2-party system, so it doesn't seem to be related to that. You could say, you know, we have lobbyists, but there are powerful lobbyists in other countries as well. You could say, you could reach for a number of explanations, but what I'm going to talk about is basically two main things that have produced our employer-based system and the lack of universal coverage. And one has to do with just a path-dependent story of the history of how we got what we've got. And the second has to do with the fact that the US has very weak political parties. And I gave, this time last year, a talk to many of you about why the US has weak political parties. But it makes them particularly susceptible to the power of outside groups, and we'll see that at play here. So let's get back into the start of why we got the employer-based system in the first place. And it goes back to World War II. During the Second World War, the government instituted wage and price controls. They froze wages and prices. But of course, it was also the case in World War II that there were massive labor shortages because so many people were off fighting in the war. And so employers were competing for workers and wanted to be able to compete over wages, but the law banned that. So in 1943, the Labor Board made a ruling that said, trying to help with this problem, that said benefits wouldn't count. So if the employer gave you new benefits or better benefits than an employer who was competing for your services, that wouldn't count as violating the wage freeze. And as a result of that, we got a massive increase in what had been quite a small program of employer-based insurance. And then after the war, it took off. But that was basically the sort of jump start of our employer-based system, purely contingent fact about World War II. And it creates a world in which directly or indirectly, somewhere between 160 million and 180 million Americans get their insurance through employer-based systems. And most of those people, bracketing the last 3 months, I'll come to the last 3 months in a little while, most of those people, for most of the time, have been relatively happy with that insurance, even though the quality of that insurance is declining because the costs of providing it are growing up. And that is forcing employers to offer less generous plans because from an employer's point of view, whatever they spend on an employee's health insurance is just part of their wage cost. It's just a part of the wage cost that the employee doesn't see. But from the employer's point of view, their wage bills are being driven up by the increased costs. So, but that's a chronic problem. It's not a crisis. It's a sort of gradual decline in the quality of healthcare for many people. But for the most part, most people, very big chunk of the population has employer-based insurance with which they're largely satisfied. So there are two obstacles to universality. One is that it means that what would be a very big group of people demanding universal health care are not demanding it because they've already got what they think is adequate health care, and they're skeptical and they're made nervous by proposals to change it. Secondly, I mentioned Medicare in particular, Medicare and Medicaid, but particularly Medicare, which was enacted in 1965. And Medicare is a universal system, single-payer universal system, what in other contexts get decried as socialized medicine. But the difficulty that it creates for expanding health insurance coverage to others in the population is, again, the over 65-year-olds already have health insurance. So that's another big group that would be lobbying for, or would be at least mobilizable to vote for universal health care, that doesn't have any reason to do that. And indeed, they might be skeptical of moves to do that because if there were a universal system, maybe the coverage wouldn't be as good as the coverage they currently have. And indeed, if you go back to the Democratic primaries and you look at depending on who you believe, between $30 and $40 trillion cost estimates on some of the proposals for Medicare for All, you could understand why the AARP, which is one of the most powerful lobbying organizations in America, wouldn't have much of an incentive to get behind Medicare for All, and might even, perhaps not very publicly, but might even behind the scenes be resistant to that. So one of the things that people in my seminar are learning is that when you want to enact a public policy, you need to think about what the coalition is to do it. Who's going to put together a coalition to achieve the change that you want to achieve? And this is a really tough proposition because the combination of the employer-based system and Medicare, which is a hugely popular and very successful system of health insurance for the elderly, takes off the table many people who would be in a coalition and potentially makes them mobilizable in a blocking coalition, which is what Obama discovered when they were enacting Obamacare. So that's one of the biggest obstacles historically, is that we came by the system in the way that we did, and that makes it extremely difficult to expand it. Furthermore, if you look at other programs, Medicaid is stigmatized as a poor people's program, so people tend not to want to expand that. And it's caught up in what we call fiscal federalism, that because we have the provision of collective goods in the United States, some at the federal level, some at the state level, and some at the local level, it tends to be the case that different parts of our federal system basically pass the buck to other parts in the federal system. Just to give you one example of this, in the 1970s, there was a discovery of psychotropic drugs and antidepressants, so thorazine and lithium. Many people who would have spent their lifetimes in mental hospitals could now live on the outside of those hospitals. So if you go up to Connecticut Valley Hospital in Middletown in Connecticut, or Creedmoor in New York, or any mental hospital in America, what you will see is maybe, I think at CVH there are about 7 or 8 buildings, 5 of which are boarded up. So a lot of people were released to become outpatients on these drugs that made people who had been unable to live outside institutions able to. But it also coincided with a massive fiscal crunch for the states. And so the states, which were basically paying for those hospitals, this is the stagflation, the 1970s, lots of bankrupt states, instead of turning that money over to the cities, which is where all of these people who were being released from the hospitals live, they basically just put it to their own bottom lines and saved the money. And so we got in every city a massive increase in the homeless populations in cities. With that, and the cities, of course, were also under massive fiscal stress, and they did not have the ability to pay for them. And a lot of those people wound up in the criminal justice system. So it's an example of the malevolent side of fiscal federalism. And the same thing has happened with Medicaid, that the federal government has stopped the growth in their contribution by just giving block grants to the states and telling them, if you want Medicaid to get any better, you can raise your own state taxes and pay for it. So it's just, another piece of the system that it stands in the way of universal care. So what did Obama achieve? They increased coverage for about 20 million people. Before the pandemic hit, there was still about 32 million uninsured people in America and 44 million what we call underinsured, that their insurance, even though they had it, was unlikely to cover many of the medical issues that they had. These numbers have surely gone up. The Kaiser Foundation now estimates that since March, 27 million people have lost health insurance. Some of them will get it back, but many of them, for reasons I'll talk about a little bit later, are moving from parts of the labor market that gave them health insurance coverage to parts that are unlikely to give it to them. So those numbers, despite Obama's achievement, probably look substantially worse today than they did 3 months ago. Yeah, again, this is before the pandemic hit, but you can see that after the passage of Obamacare, we went from about 17% coverage, and we before the Trump administration, we had got that number down to about 10%. And so given the history and given the obstacles, it was not an insignificant achievement. Okay, so what were the big challenges to enacting Obamacare, and how did Obama overcome them, at least to the extent of getting the policies that he got? The first was the sticker shock problem. The American health insurance system is tremendously expensive. If you look at what we spend on health care compared to all of the other advanced democracies per person, we spend more money for less good care by just about any metric, substantially more money for less good care. So one reason is the lack of universal coverage itself, because it means that uninsured people tend to use emergency rooms as the doctor's office. When they get sick, they go to the emergency room, which cannot turn them away. It has to treat them, and that's the most expensive possible way to treat people, because the overhead of running an emergency room is just unbelievably high. And so what tends to happen is those costs then get the hospitals pass those costs on in the form of essentially in padding to people who are insured, and that's one of the reasons why the rate of medical inflation is significantly above the rate of regular inflation. And so that's one reason. But a second big reason is traceable to what we have to pay for drug prices. In George W. Bush's administration, they enacted Medicare Part D, which is free prescription drugs for seniors. So the government's paying for those drugs. And at the time, Republicans on the Hill were pushing for the government to be able to negotiate drug prices with Big Pharma, because the government's a huge, by far the biggest purchaser. They have a lot of market power to do that. But the Big Pharma is a very powerful lobby, and you can see here when we were heading for Medicare Part D, was one of the big ramp ups in pharmaceutical lobbying, and they managed to kill the provision in the bill that enabled the federal government to negotiate drug prices with Big Pharma. So unlike every other country, we have no capacity to do that. And so this is a huge, huge multi-billion dollar addition to the cost of healthcare since it's been enacted. You can see from my chart here that every time, this is when Obamacare was going through Congress, then of course, again, big ramp up. And this is when the Trump tax bill is going through Congress, again, a big ramp up. And we'll see why else there was lobbying in a minute. So Obama had run on revisiting this in 2008, but he finally gave up in the face of the lobbying. And the problem that they had was they were fighting not one, but two big lobbies. Because the other thing that Obama had run on was creating a public option. So the idea about public option was twofold. The idea was that you create a public option. You first of all, in areas where there was only one private provider, the government creates competition so that the private provider doesn't have the possibility of monopoly pricing in that local market. There would always be a government option as well. But secondly, the idea behind the public option was that it would create the possibility of slowly evolving towards universal coverage, because more and more people could choose the public option rather than their employer-based system. They might find that the employer-based coverage was getting worse for the reasons I've already talked about, or they might move from a job that gave health insurance to one that didn't, and so they would be able to have a public option. For that very reason, the public option was immensely threatening to the insurance industry, because it threatened, first of all, to limit their possibilities of monopoly pricing in single supplier markets. But secondly, it threatened to put them out of business, because if the public option became the path towards universal coverage, that would be also the path towards putting them out of business permanently. So what Obama discovered in 2009 and 2010 when they were writing the bill was that they were fighting both Big Pharma and the insurance industry, and they're both extremely powerful lobby groups. And so at some point while they were trying to work this through informally, because they did it informally before they send the bill up to the Hill, they were through the committees. They came to the conclusion that they couldn't fight both these battles. They couldn't win both these battles. And so they gave up on the cost controls. And the insurance industry gave them a fig leaf of some apparent cost controls that were spurious, just to hide the fact that they had basically given up on the cost controls. And then the Big Pharma got behind and started supporting the bill, which is what they wanted. It took, not only did it take the heat off a lot of congressmen, congresswomen, and senators, they actually started to support the bill, getting the bill through Congress. So that left the public option. And of course, divide and conquer. Obama thought they had split the two biggest lobbyists, and that's good. In my course, we're always talking about how you need strategies to split the blocking coalition. So this is what they were doing. They were splitting the blocking coalition and kicking the can down the road with respect to costs. Big problem for later, because once you start talking about Medicare for all, as Sanders and Warren and others were doing in the primaries, the cost problem gets priced into the way in which people price Medicare for all. So that left the public option. And as I said, this was very threatening to insurance companies. So here's the president talking about the public option.
An additional step we can take to keep insurance companies honest is by making a not-for-profit public option available in the insurance exchange. Let me be clear. Let me be clear. It would only be an option for those who don't have insurance. No one would be forced to choose it. It would not impact those of you who already have insurance. In fact, based on Congressional Budget Office estimates, we believe that less than 5% of Americans would sign up. Despite all this, the insurance companies and their allies don't like this idea. They argue that these private companies can't fairly compete with the government. And they'd be right if taxpayers were subsidizing this public insurance option. But they won't be. I've insisted that, like any private insurance company, the public insurance option would have to be self-sufficient and rely on the premiums it collects. But by avoiding some of the overhead that gets eaten up in private companies by profits, excessive administrative costs, and executive salaries, it could provide a good deal for consumers. It would also keep pressure on private insurers to keep their policies affordable and treat their customers better. It is only one part of my plan and shouldn't be used as a handy excuse for the usual Washington ideological battles. But I will not back down on the basic principle that if Americans can't find affordable coverage, we will provide you with a choice.
So the reason Obama got a standing ovation when he made that speech, this was his State of the Union in 2010, I believe. So the reason he got a standing ovation was that he had been sending signals to the industry that he was wavering on the public option. And indeed, he'd even made a couple of speeches in the months before this to the effect that maybe the public option was not going to be essential to the bill. And this mobilized the progressive wing of the Democratic Party, and they, counter lobbied the administration that they couldn't give up on the public option. And so Obama decided to put it back in, and that's why he was getting a standing ovation. So the public option looked like it was going to be in the law. However, in the United States, you need 60 votes in the Senate to enact a piece of legislation. And otherwise, this is 60 votes this is to stop a filibuster, to have a closure vote, as it's called. And the administration basically had just 60 votes. Once they only got 60 votes after a multi-month fight in Minnesota over Al Franken's seat that was being disputed in the courts. But they had 60 and only 60 votes. And what happens in our system of very weak parties is that if your vote is essential to the passage of a bill, is that individual congresspeople and senators can, what economists say, extract rents for their support. And of course, so this created a field day with the Obamacare bill because there was not a single vote to spare. And so there's something called the Cornhusker kickback, which was, massive federal support for Medicaid expansion in Nebraska. But the one that, and there were many other people who were basic senators who were extracting this and that from the administration in return for supporting the bill. But the most problematic one turned out to be Senator Joseph Lieberman of Connecticut, who had been a Democrat, lifetime Democrat, but had actually lost in a primary and ran as an independent and got reelected to the Senate. But he caucused with the Democrats, and he was basically supportive of the legislation. But let me show you what he had to say about it.
With us now, Senator Joe Lieberman of Connecticut. You just heard the White House top advisor on such things, saying that it is likely that both the House and Senate will finally come up with some kind of healthcare bill that has some sort of public option in it. What's your take?
I hope not. In other words, I'm all for healthcare reform. We have a system that needs fixing, but we've got some more urgent problems than that. And the first, most urgent, is to fix our economy, to get it creating jobs again. And I think that a public option will actually hurt the economic recovery and our long-term fiscal situation, because it will end up causing the government to raise taxes, will probably raise premiums, or it will put us further into debt. I want to be able to say yes. There's so many good things we can do to make health insurance more affordable and to extend it to people who don't have it now. But I feel so strongly about the creation of another government health insurance entitlement, the government going into the health insurance business. I think it's such a mistake that I would use the power I have as a single senator to stop a final vote.
But wouldn't that mean that you might wind up with nothing instead of something?
Well, the truth is that nothing is better than that, because I think we ought to follow, if I may, the doctor's oath here in Congress as we deal with healthcare reform. Do no harm.
I'm going to ask you this question because I want to give you a chance to respond to it.
Okay.
Some of your critics say that the reason that you are so dead set against the public option is because there are so many insurance companies headquartered in your home state in Connecticut, and they've been some of your biggest supporters. What have they given you this year? $400,000, something like that. Does that have anything to do with your position on the public option?
No. I wish people would come out and debate me on the public option instead of questioning my motives. That's not the reason, but I will say this recommendation of a public option, a government health insurance company, takes our government down a road that we've never gone down before. In other words, we believe in a market economy. It's what's created the great American middle class, but it doesn't have a conscience. When it behaves badly, we regulate it, companies, we sue them. I've been angry at oil companies. I never had the idea that the government should go into the oil business to make oil companies behave better. I think this would be a terrible mistake.
So there you have it. Of course, any economist would tell you that that last piece of logic is spurious, because the difference between insurance markets and the market for something like oil is that insurance markets inevitably confront market failures because they're susceptible to what economists refer to as adverse selection. That is, if you don't have universal, this is another thing that contributes to the cost. If you don't have everybody in the system, the people who want to buy insurance are the people who are sick or likely to be sick soon, and the people who are unlikely to be sick soon are not going to buy insurance. And so that's what they call the problem of adverse selection. It selects out the people who would keep the cost down if everybody was part of it. Nonetheless, 10 days before the final vote, Lieberman said that unless they removed the public option from the bill, he would vote against it. So they removed it. And so in effect, Joe Lieberman is the reason why we ended up with no public option in the bill. And so you see that, in fact, both Big Pharma and the insurance industry managed to prevail. Subsequently, the law was challenged in the court in a case called NFIB. That's the National Federation of Independent Businesses, the lobby group that represents small business, versus Sibelius. And interestingly, and this is what people most commonly know about this court case, Justice Roberts, Chief Justice Roberts, said, well, the individual mandate requiring everyone to have insurance, which is part of this imperative to deal with the adverse selection problem. If you don't require people to have insurance, the ones that are healthy are going to be the ones that select against buying it. He said we can call it a tax, and that it is within the government's power to impose a tax. The federal government can impose a tax, and so the bill survived. But he also, and this is a less well-known part of the decision, he also said that another part of the bill, which is basically what the Obamacare bill did, was say to the states, we want you to massively expand Medicaid coverage for the poor. And we, the federal government, will give you the more than 90% of the cost of that. But if you reject it, you're not going to get any Medicaid funding from the federal government. So in effect, you will lose the Medicaid funding you currently have. So this was in the bill. And Roberts and the conservative majority said that is an unacceptable coercion of the states, even though I don't think anyone would have predicted the court would do that. So even though it did preserve the individual mandate, it greatly weakened the capacity of the legislation to improve Medicaid funding for the poor through conditioning Medicaid expansion on accepting the cost, the money from the federal government. So states where there were Republican governors and legislatures who were strongly opposed to this were able to refuse to take that funding, and many of them have. Then in 2017, the Trump tax bill abolished the individual mandate since it was now legally a tax. And that is why the Trump administration is now back in court saying, well, if it's a tax that we have abolished, then there's no reason to keep the bill. So that's the litigation currently in front of the court. So what could be done? As the last part of my title was what can be done about it, and I promised some good news. So Valerie mentioned my book with Michael Gratz, The Wolf at the Door, The Menace of Economic Insecurity and How to Fight It. So what we argue is for bottom-up Medicare expansion. And so the idea here is somewhat similar to the public option, but it's a path to Medicare for all. And the idea is most people can get on their parents' insurance until age 26. And then they lose it if they don't have their own. So we argue that start by adding 26 to 30-year-olds because they're cheap to insure and mostly they don't get sick. And then allow them to keep their insurance as they age, and allow others to buy into the system if and when, say, to buy into Medicare if and when they lose or become dissatisfied with their own insurance. It's a cheaper way to do it because you start with the cheapest people to add. It takes account of the fact that over time, many people are going to be losing employer-based coverage, and it also builds the coalition over time. As I said earlier, when you're thinking about enacting something, you got to think about who's the coalition and who's the blocking coalition. We've talked in my seminar about loss aversion, that once people have something, they don't want to get rid of it. So even a 27-year-old who might think they're not going to get sick won't go out and buy insurance if you tell them what it's likely to cost them if they get sick. But if they have insurance and you say, now you're going to lose it, they'll fight to keep it. So that's what we learned from Danny Kahneman, this idea of loss aversion. He won the Nobel Prize for Literature. Actually, he and Amos Tversky dreamed it up, but Tversky had died. The only time a psychologist has ever been given a Nobel Prize for economics, this idea of loss aversion. So you increase the coalition, and that, given the history of where we've come from, it builds the coalition for it over time. And there's reason to think that this is an idea whose time has now come. This is another slide teachers in my seminar have seen several times. It's basically a panel study that has been done by the Bureau of Labor Statistics of late baby boomers' employment. And the takeaway point here is that a young person today should expect to lose their job or to change jobs between 12 and 15 times in their lifetime. So the era when people finished their education and then got a job for 30 years and retired has gone. Jobs first went to offshoring, to globalization, cheaper wages and all that. Increasingly now jobs are going to technology. And that means that long-term employment insecurity is a thing of the past. And of course, it means that the current system is unsustainable of employer-based coverage. And this is going to weaken the power of lobbyists. If you think about gun control, what happens with gun control is every time there's a school shooting, voters get angry and say something has to be done. But the lobbyists know that all they have to do is wait, because voter attention will go on to something else, and it won't, when the election comes around, it won't be the issue that they vote on. But here we've got a problem that is long-term unsustainable. More and more workers are going to lose first quality insurance and then probably all insurance. The pandemic is going to accelerate the growth in voter awareness that the employer-based system is unsustainable. As I mentioned, at least 27 million seem to have lost coverage, and more probably will. So in short, that turns a chronic problem into a crisis. And that's a good thing, because politics tends not to respond well to chronic problems. Amartya Sen, for example, points out you don't get famines in democracies, but you do get chronic poverty, right? So it's when something goes from a chronic problem to a crisis, it gets onto the political front burner. And so the convergence of the coronavirus has effect on in people's insurance in the short term, with this long-term structural change in employment markets that makes the employer-based system unsustainable, is a good thing. And so we can end on a hopeful note. Thank you for your attention.
Okay, we have some time for questions. I have a question that came through the chat, but after this question, if you want to just call them out, as long as it's orderly, that will be fine. So the first question is from Catherine. What will it take for Medicaid to not be stigmatized as a poor people's program anymore?
It's a very difficult problem. The best way out would be the return of a public option or our Medicare, our bottom-up Medicare expansion that would largely just replace Medicaid. And one could imagine, for example, if there is a Democratic sweep in November, one could imagine the return of a public option that could be subsidized by the federal government to make it appealing to people who are currently on Medicaid. So you would start to move away from the state-based system for insuring poor people.
Are there any other questions from out in the crowd?
Question. Who do you think in the world is doing the best job as far as their healthcare system, and why?
Well, if you look at voter satisfaction, probably the UK. Well, UK and Canada have a very high levels of voter satisfaction, but the British system was created in 1946 by the Attlee government, the Labour government after the war. And unlike what we did in the US with this piecemeal expansion of different coverage of different populations, which then has the downside problem of, destroying the potential coalition for a universal system. They did it all at once. It's even more of a public system than the Canadian system. The Canadian system, the government provides everybody with insurance, but you still have private doctors. In the UK, doctors, the government pays the doctors as well. So the doctors are in effect civil servants. Well, if you look at the public opinion about the National Health Service, it's the most popular institution in Britain. When Margaret Thatcher was rolling back the welfare state in the 1980s, she couldn't touch the NHS. It's basically bulletproof. I saw some polling just recently that the NHS is more popular than any other institution in the UK, including the Queen, who is the second most popular institution. So they have good universal coverage. Canada has good universal coverage. But almost all of the industrial democracies on just about any measure have better coverage than we do. The German system is very good, for example. Yeah.
Okay, I have a question from Jen Fraser. She asks, how has the increased use of walk-in medical units impacted this scenario?
So we're talking about replacing more and more inpatient with outpatient, basically. Well, it's a form of cost cutting. The overhead of running hospitals is just through the roof. It's partly technology, it's partly better treatments. We saw that what I told you about antidepressants and psychotropic drugs, it doesn't always work out that well. Yeah, that population, which previously was living in mental hospitals, a lot of them are now living in the streets, supposedly coming into, CMHC in New Haven to get their meds every day or whenever it is. But a lot of them, there's not the support for them. There are not enough, halfway houses. Sometimes it's a byproduct of the pressure for cost containment. Sometimes it works, but it doesn't always work as well as one might hope.
We have a question from Marjorie. I thought doctors are against universal health care because they will make less money, and it is a matter of capitalism against socialism.
That is true. The medical establishment has fought the creation of a universal system. And indeed, my colleague in Yale Political Science Department, Peter Swenson, is about to publish a big book on the history. He's probably the best authority in the world on this. A big book on that, about the role of the medical establishment from the New Deal forward in opposing efforts at universal health insurance. But that's a battle that's going to have to be had. But it's a battle that's been had elsewhere. In Britain, the doctors opposed the creation of the NHS and eventually failed. The other thing to say is that the current status quo is not that great for physicians, because the current system of HMOs, for which many, if you look, I don't have the statistics right in front of me, but if you look at the number of physicians in private practice versus HMOs, it's gone way down since the Clinton administration, basically. When Bill Clinton was Bill and Hillary were trying to pass universal health care in 19 92, which they ended up failing to do in the end. But for a while, it looked like they were going to succeed. And that was the era of the creation of the HMO. And many, many private practices shut up and the doctors went to work for these HMOs. And they're not very lucrative to work for, and they don't like it very much. So it's not like they're defending a system that is that great for them. But I think the real reason for hope is the structural change in labor markets that I'm talking about. The demand for universal coverage is going to go up. But I don't believe we would end up with something like the British system. I think we would end up with something like the Canadian system. I think the doctors will not end up as civil servants.
Ginger Lee asked, due to the current status of the nation's economy, isn't this a good time to consider massive change to healthcare policies? Why not do this now as we are trying to rebuild? It's also Lauren Friedman.
Yes. You know, yeah, I said that I mean, basically, as I was saying at the end of the lecture, that the combination of the big structural change with this massive shock to, you know, tens of millions of people's health insurance may make this the perfect moment for the Biden campaign to get behind something like this, because it's a confluence of a big structural change, which is the problem, has the demerit of being a chronic problem, and we don't respond very well to chronic problems. But we've also got a crisis, you know. So it's a crisis layered on top of a chronic problem. And in terms of putting together the coalition, that's great. It is really a moment of opportunity, I think, and this should be a centerpiece of the Biden campaign. That's what we argue in our book.
Brandon Barr asks, how might change impact hospitals and other institutions that favor taking private insurance?
You know, it will be a big fight among lobbyists. So, you know, basically, you know, the standard academic literature, what it tells you is that the big lobbyists usually they've got their eye on the long run, and voters tend to have their eye on the short run. As I said, the classic example is what happens after a school shooting, when, you know, there's this never again, there's got to be legislation, everybody jumps up and down for 3 weeks, and then it just dissipates. That's the sort of standard model of lobbyists. So, you know, there's even a guy at Columbia called John Coffey who wrote an article called The Sine Curve of Regulation, so that, you know, voter sentiment goes like this, but the lobbyists have their view on the long game. And so for voter sentiment to be consequential, you've got to have a confluence of, like we've got all three here, an election, a short-term crisis, and a long-term problem. And so to be sure, people will fight it tooth and nail, and powerful groups will fight it tooth and nail. But the other thing to say about it is why it's maybe an idea whose time has come, is that because of all the problems with Obamacare, with the rollout, and the fact that, you know, Obama had said if you want to keep your doctor, you can keep your doctor, and the lobbying against it in 2012 and 2016, it was a pretty unpopular law. It's not unpopular now. It's a popular law. If you look at the data on public opinion, there's much more favorable. Many people, the majority are in support of Obamacare. So, you know, Trump is off in the court trying to get the court to strike it down. That decision will not be handed down before the election, but it's more popular, and it'll be a less heavy lift, a less heavy political lift, I believe, in 2020 than it was in 28.
We have one more question from Vanessa. She asks, how can we begin to raise our students' awareness or understanding about these large issues of healthcare that are so complex and multi-layered when, as young people, they often are not even aware of this need?
Well, that's why we're teaching the courses we're teaching and designing the units we're designing.
Okay. So since we're at 12 o'clock, I'd like to thank Ian for this enlightening talk on universal health insurance, and also for starting off our Friday with some hope, Ian. So thank you for this talk today.
You're welcome.